So it's a pleasure to be here at this panel. My disclosure that I don't have is I'm on the board of the California Orthopedic Association and very happy to be here with my friends. I'm going to pitch this to the occasionalists among you as well as the specialists among you in terms of treating this condition, a very common one, basal joint arthritis. First thing you've got to do is differentiate what the reason is that the patient comes to you with pain, and you identify that it has something to do with the thumb ray or the radial side of the wrist. And so this is basic, but I go through this with every patient, and you should too. Make sure you're aware that it's not a de Quervain's tendinitis, can be both, and you know the characteristic findings in terms of the first dorsal compartment and pain on pressure, pain on maneuvers such as the Finkelstein's maneuver, thumb in the fist, and then going into ulnar deviation or resisted thumb abduction, and stressing that, and sometimes putting your finger right over the first dorsal compartment. To the right, upper trigger thumb, of course, people may not be able to identify where they have pain. You may have to decipher that and examine them for tenderness on the palm side, the A1 pulley, and of course, if they demonstrate clicking or locking right in front of you, that makes your task a little bit easier. If you're looking at the basal joint, you also need to consider the metacarpal phalangeal joint because some of these people have compensatory hyperextension, which you may need to address if you're treating them surgically. And wrist arthritis, such as a case that Prosper showed you earlier, radioscaphoid joint or slack wrist, that obviously can generate pain in the same general region. I think imaging is important, but you need to put that in context. So those of us who do hand surgery are very aware of the Littler-Eaton stages based on the radiographs. Those are the people I trained with in fellowship. The importance of this classification system, however, is that it's only one factor. And you need to remind yourself that just because something looks bad radiographically does not mean that they need surgical treatment. I have plenty of people who look like stage 3 and stage 4 that I have treated non-operatively. Conversely, there are people who look essentially normal on fluoroscopy who have intractable pain and go through the motions, go through conservative treatment, and want to have a surgical amelioration of their pain. So you've got to remember the radiology does not equal what you're going to do clinically. Conservative treatment is important. I offer bracing, I offer cortisone injections. People come to me after they've seen another physician, and sometimes they have fat atrophy. Sometimes they have depigmentation. So the best steroid for large joint injections, such as for the shoulder and the knee, are not always the best choice for the hand surgery type patient. I've been using dexamethasone for almost 30 years. My mentors 30 years before that. Why? It's clear. It leaves no residue. There's no depigmentation or fat atrophy, and actually there's no upper limit. So lots of people come in and say, well, I've heard I can only have 3 injections. Well, that data is A, very spurious, and B, with this medication, there is no upper limit. Some recent studies have shown that you can expect 80% of your patients may not need surgery or come to surgery. So, those of you who are not super familiar with this anatomy, I think it's very appropriate for you to start treating the patients and giving them the patient information and doing the conservative treatment first. Entirely appropriate and recommended. So if the patient comes to surgery, there are many, many options. And what's best is really what's quote unquote best in your hands. This is just a partial list of the common procedures, including trapezium resection, the classic tendon through bone, LRTI, or my variation is abductor pollicis longus, and I'll show you. Small joint arthroscopy has a role. Devices such as the tightrope and others. Some people do implants, and some people do an arthrodesis. These are just all reasonable choices, and what's best is what's best in your hands. So I'm going to review a couple of techniques that I think are worth talking about. The APL suspension is what I did the first 10 years of my career. It is very similar to the LRTI. I found it easier to provide the tension, and instead of harvesting flexor carpi radialis here, I would harvest abductor pollicis longus, either the whole thing or one slip, and the drill holes are the same. You harvest half, you have to put drill holes in the thumb metacarpal base, and then into the index. This is the classic version. There, of course, are variations where people are doing less drill holes, they're wrapping one tendon around the other. There's lots of variations. One of the dangers of this is if you break your bone tunnel, there's always a little trepidation as you're putting the awl and expanding that hole or tunnel to pass the tendon through. Sometimes it's too small, you go back and forth. There is a little bit of fiddling with this operation, to be sure. If you use the abductor pollicis longus, you would secure it on a tendon weave to the extensor carpi radialis longus. In general, expect this to take about 90 minutes of OR time. Now, trapezium resection and pinning is a popular approach, particularly those of us in California, as extolled by Roy Meals and his colleagues in Southern California, Prosper Benheim's way. And he declared that he'd been doing this for decades and had really, really good results. And so the key thing here is to resect the trapezium and then provide temporary pinning for placing the thumb metacarpal in an appropriate position. If possible, some quote-unquote distraction. And he called this a hematomoplasty because his concept was that with the removal of the trapezium, the body develops scar tissue, and that after pin removal, the result is an excellent result. So these are two of the classic studies that introduced everybody to this concept, and the photograph and diagram included in the paper. This is one of my own cases. I'm just going to take you through it. So if you're going to operate, I implore you to use imaging or fluoroscopy. I've walked into a room when, another service was operating on the patient, and, I told them they had done an excellent job resecting the scaphoid. You do not want to have that happen under your watch, okay? So as many times as I've done this, I always make myself take a fluoro shot to make sure I've got the correct bone under my loops. So that's the, let's see if I can work the laser here. Well, so that's the first panel. And the second panel is trapezium excision. This bone is much bigger than you think when you're trying to get it the heck out of the wrist, I'll tell you. And I'm surprised every time by what I have to do to remove it. And then the next panel on the upper right is thumb traction. And the fourth panel on the top is an implant. Now, if you're doing the Roy Meals style trapezium excision and hematomoplasty, the angle of that K-wire would probably be a little bit lower. In this case, I'm using an implant, so this is just part of my operation. This is a K-wire with a nitinol loop at the end, and if you follow on the second panel, the lower panel, the K-wire with the loop is used to advance this device, which is the tightrope. It's a suture, or it's called suture suspension, and it has 2 washers. So you bring 1 washer up to the thumb metacarpal, which is where you've had your initial incision, and you make a small counter incision over the index so the K-wire can emerge, and then the device can emerge, and then you can fasten this with tension. So here I'm showing push-pull and good stability and good position of the thumb. So why do I do something a little bit more complicated? Well, you know, I'll go through that in the next few slides. The classic incision for trapezium work is called the Wagner incision. It's a volar and radial incision. I've been able to remove trapezii through this incision, which I think is a little more modest and cosmetic. And so here is the AdSense showing the space that I have achieved through resection successfully of the trapezium. Frame number 3 shows that K-wire with the nitinol loop that I'm using to advance the suture system. And the lower right shows that suture system being positioned and being ready to be advanced. The next panel shows me pulling that through, and then upper right shows the second washer being placed and applied. That third panel shows the very modest index incision and the thumb incision all closed. So this is my usual appearance after I've resected the trapezium. I suggest this morselized technique over trying to take the trapezium out whole. I find that much more difficult. I find it much more risky. I don't like it if the radial artery or its branches are injured, or I've decimated the flexor carpi radialis at the base of my wound. This is an animation by the company that makes this mini tightrope. In this image, it shows the 2 incisions. The trapezium is being removed and nibbled. This is the initial instability, and this is the K-wire going across the thumb metacarpal to the index. It's important to try to get the index exit point away from the dorsal peak of the index, because that can irritate the patient post-op in terms of the placement of the second washer being applied right there. So this takes me about an hour's time, and I have a few conclusions to share with you. First of all, make sure of the diagnosis, because you don't have to have just basal joint arthritis. You can have any of those other conditions concomitant. And then you have to prioritize as the doctor with the patient, you know, which of these conditions is the one that's the most troublesome. Or you may have to do multiple things, like pinning the metacarpal phalangeal joint for bad hyperextension, or doing a volar plate arthroplasty, or doing the dequervain's release or the trigger release at the same time if they're all kind of simultaneously troubling the patient. Use the basic imaging. I don't use advanced imaging. I don't really care what the shape of the trapezium is. I'm going to get rid of it anyway. So a fluoro or some basic x-rays are enough. Start with the bracing and the cortisone. That's the 80-20 rule. You can have happy patients, and you can, you know, pound your chest and say, hey, I'm getting you through without surgery. Isn't that preferable? You know, Mrs. Jones, Dr. Smith, whatever. In terms of surgical treatment, there are many, and I think it's dealer's choice. I use the suture suspension device because I don't need the pin fixation. I get the patients out at 1 week and start them gripping and moving. Simple, however, may be the best. Doing the Roy Meals approach, doing the trapezium excision, and having the pin in place for about 5 weeks is what's recommended. The important thing to realize is, you know, whatever sort of big data studies we have show that there's no significant difference at the 1-year point between all these treatments. So I think do what you're comfortable with, start with the conservative treatment, and good luck with your patients. Thank you.